Dr. Lena, for that very kind introduction. And I'm Moh Sim. I'm from the Department of Laboratory Medicine from Hudikpat Hospital, and thank you all for attending the session. Before I start, I'd also like to thank Dr. Lena, Dr. Sam Vasikran, and the APFCB for inviting me to share my session, to share my share my thoughts on interpretive comments on diabetes tests. I'll be covering the following in my presentation: a recap of diabetes mellitus, laboratory tests in diabetes, and ending with some case studies. So diabetes mellitus is a group of metabolic diseases characterized by hyperglycemia, resulting from defects in insulin secretion, insulin action, or both. And it is well known that the chronic hyperglycemia of diabetes is associated with long-term damage, dysfunction, and failure of different organs, especially eyes, kidneys, nerves, heart, and blood vessels. About 460 million adults aged 20 to 79 years old are living with diabetes. And the number of patients with diabetes is projected to increase significantly. And by 2014, this number will double in Southeast Asia, Middle East and North Africa, and Africa. This also means that the global cost of diabetes will rise exponentially. And by 2040, you can actually see a doubling of the healthcare expenditure due to diabetes, particularly in Southeast Asia, in Middle East and North Africa, and Africa. So there's actually a global diabetic pandemic. There are two main types of diabetes. Type 1 diabetes is caused by immune-mediated beta cell destruction, and this usually leads to absolute insulin deficiency. Type 1 diabetes commonly occurs in childhood and adolescence, but can actually occur at any age. These patients are rarely obese and can present with other autoimmune disorders, such as Graves' thyroid disease. They are also positive for autoimmune markers such as ICA, autoantibodies to islet cell, and GAD antibodies, or glutamic acid decarboxylase antibodies. The more common type of diabetes is actually type 2 diabetes. And in type 2 diabetes, the issue is insulin. There's an actually disorder of insulin action and insulin secretion. Type 2 diabetes is frequently undiagnosed for many years, and that is because hyperglycemia develops gradually. And at earlier stages is actually often not severe enough for the patient to notice any of the classic symptoms of diabetes. Type 2 diabetic patients usually do not require insulin for survival, although at the latter part of their disease, they may require insulin treatment. Patients with diabetes can present acutely with DKA or diabetic ketoacidosis. They can also present with hyperosmolar, hyperglycemic, non-ketotic coma. However, of greater significance and global concern is the fact that a significant number of them can present with long-term complications. And these long-term complications can be macrovascular or microvascular in nature. Microvascular complications of diabetes include eye complications. The hyperglycemia causes retinopathy, cataracts, and glaucoma. Microvascular complications also include kidney disease, chronic kidney disease, and nerve damage. Macrovascular complications include cerebrovascular disease, such as transient ischemic attacks and strokes, coronary heart disease, and peripheral vascular disease, and even gangrenous states. Hence, there's really a need to diagnose diabetes early and effectively for three main reasons. The first is diabetes is associated with reduced life expectancy and considerable morbidity. About 1/3 of people with diabetes do not even know they actually have diabetes. Thirdly, early and aggressive treatment of diabetes and its associated metabolic derangements can actually prevent or delay the progression of major complications and therefore significant morbidity and mortality. There are 4 diagnostic criteria for diabetes mellitus. A patient is deemed to have diabetes if his or her fasting plasma glucose is equal to or greater than 7 millimoles per liter after a fast of at least 8 hours. A patient is considered to have diabetes if the random plasma glucose is equal to or greater than 11.1 millimoles, and the patient is actually symptomatic, the patient is considered to be diabetic if a 2-hour plasma glucose level during an oral glucose tolerance test, or OGTT, is greater or equal to 11.1 millimoles. And last but not least, a patient is considered to have diabetes if the HbA1c is equal to or greater than 6.5%, and the HbA1c test should be performed in a laboratory using a method that is NGSP certified and standardized to the TCCT assay. In the absence of unequivocal hyperglycemia, the result should be confirmed by repeat testing. In other words, if the first result is unclear, you can use the same test, or you can use any of the other tests to actually confirm your diagnosis. There are also diagnostic criteria for prediabetes, and prediabetes actually represents this intermediate state between normal and diabetes. A patient is diagnosed as having prediabetes if the HbA1c is between 5.7 to 6.4%, if the fasting plasma glucose is between 5.6 to 6.9 millimoles per liter, and if the 2-hour postprandial glucose during OGTT is between 7.8 to 11.0 millimoles per liter. So let's move on to laboratory tests in diabetes. Laboratory investigations for diabetes include glucose and HbA1c. And glucose is usually used for screening and is also used for the diagnosis of diabetes. HbA1c is well recognized as a monitor of diabetes control, and of late has also been used as a marker for the diagnosis of diabetes, as shown in one of my earlier slides. As mentioned earlier, diabetes is associated with many complications, one of which is actually diabetic nephropathy. And creatinine and microalbumin are useful and should be measured in patients with diabetes so that we can actually detect early signs of diabetic nephropathy. Fasting plasma glucose is the preferred test for the diagnosis of diabetes. And when collecting specimens, sodium fluoride preservative is actually preferred, and that is really to mitigate the fall in glucose concentrations due to glycolysis if there is going to be an extended time between collection and analysis. The average fall per hour, due to glycolysis is between 5 to 7% or 0.6 millimoles per liter. And I think this is particularly useful and essential, really essential, especially if you're actually collecting specimens from areas which are far away from the laboratory, because what you do not want is to have a patient, have a sample collected on Saturday morning and analyzed on Monday, and by the time it's actually analyzed, the sample is now going to demonstrate a normal glucose level. Fasting plasma glucose should be measured in accredited laboratories using enzymatic methods. For fasting glucose levels, blood should be actually drawn in the morning after an overnight fast of at least 8 hours. In the oral glucose tolerance test, or OGTT, blood is actually taken from a patient, and this is now marked at 0 hours. The patient then drinks a solution containing 75 grams of glucose, and a second blood sample for glucose is taken at 2 hours. There are advantages of using fasting plasma glucose in diagnosing diabetes. The advantages are that fasting plasma glucose is simpler, it is cheaper, and is quicker and more reproducible. Enzymatic methods are also relatively well standardized. I think we all recognize that glucose methods have been standardized and are very accurate over the years. In addition to that, fasting plasma glucose levels also correlate with microvascular disease. And it has been demonstrated that the incidence of both diabetic retinopathy and nephropathy increases when the fasting plasma glucose levels are above 6.0 millimoles per liter. Conversely, the oral glucose tolerance test, which is a little bit more laborious for the patient, okay, to perform, does have certain advantages. It is much more sensitive than fasting plasma glucose in diagnosing diabetes. It is useful in classifying individuals with impaired glucose tolerance or prediabetes states. And it is the test if you're trying to make a diagnosis of gestational diabetes mellitus. The second test that is actually commonly used in diabetes testing is hemoglobin A1C or HbA1c. And this is defined as the stable adduct of glucose to the N-terminal valine of the beta chain of hemoglobin. The blood level of HbA1c depends on two things: the lifespan of red blood cells, and this is usually approximately 120 days. It is also dependent on the prevailing blood glucose level. And because the blood glucose level is actually dependent on the lifespan of red blood cells, HbA1c is an excellent indicator of average blood glucose concentrations over the preceding 8 to 12 weeks. It's not a full 12 weeks because one has taken attrition of red blood cells, and therefore the red blood cell population will always comprise a mix of old and new red blood cells. It is well recognized that HbA1c should be performed routinely in all patients with diabetes at both the initial assessment and as part of follow-up care. Okay, and this table actually shows the different categories of glycemic control. For patients with diabetes, we actually aim for them to have a HbA1c level of 6.5 to 7.0%. Okay, a patient is considered to have suboptimal glycemic control if his HbA1c is between 7.1 to 8%, and unacceptable glycemic control if his HbA1c is greater than 8%. For certain categories of patients, you may want to have more stringent glycemic control targets, and hence this is where we may even aim for HbA1c to be below 6.5%. The pre-meal and post-meal glucose represented in these tables actually show that if a patient is able to attain these pre- and post-meal targets, by the time they are actually reviewed in clinic, they should not be too far off the HbA1c value. So this will actually give a patient who's consistently monitoring the blood glucose levels an idea of what the HbA1c when they see the patient, when they see the doctor at 3-month or 4-monthly intervals. I think it's also increasingly recognized that HbA1c targets should be tailored to the individual with diabetes. And the approach to the management of hyperglycemia depends on many factors. You can actually impose more stringent targets for patients who are newly diagnosed with diabetes, who potentially have a long life expectancy, and who do not have any comorbidities or established vascular complications. Patients who also are likely to have very low possibilities of actually developing adverse effects from intensive therapy should also be considered for more stringent targets. I think fundamentally, it's also important to know the type of patient that you're managing. So highly motivated patients with excellent self-care capabilities, okay, who understand and empower conditions also are in a better position to manage their own diabetes care, and therefore are more likely to be able to abide to more stringent HbA1c targets with less risk of hypoglycemia events. Many years ago, HbA1c was proposed as a diagnostic marker for diabetes mellitus because it has several advantages over fasting glucose. in the diagnosis of diabetes. HbA1c does not require a patient to be fasting, okay, unlike fasting glucose. Okay, and this is really very important because some of our patients, when they are fasting, they actually turn up in our clinic and are hypoglycemic. HbA1c is also not affected by short-term lifestyle changes and is a very good surrogate marker for seeing how patients actually adhere and abide by lifestyle changes. So I often tell my patients, we're actually not chasing sugars. We're actually seeing how well you abide by lifestyle measures to ensure that your diabetes is under control. HbA1c is also relatively unaffected by acute changes in glucose levels during acute illnesses or acute infections or during extreme trauma or stress conditions. HbA1c is stable at room temperature. Do not have to worry about glycolysis. And last but not least, HbA1c demonstrates less biological variability compared to fasting plasma glucose. The day-to-day variance of HbA1c is 1.9% versus 12 to 15% for fasting plasma glucose. In tandem with the proposal that HbA1c be considered as a marker for the diagnosis of diabetes was the development and implementation of the National Glycohemoglobin Standardization Program. Okay, and this was implemented in 1996. And you can see from this table that from 1993 to 2012, HbA1c methods have improved considerably in terms of standardization and accuracy. In 1993, there's a huge spread of values obtained by different HbA1c methods, and by 2012, the variation has been reduced considerably. Hence, samples for HbA1c measurements should be sent to laboratories with DCCT-aligned assays, okay, because these are actually standardized assays. HbA1c results should also be made available at the time the patient with diabetes is actually seen. And I think, again, the reason for this is that if you make the HbA1c available at that point, you are able to not only educate the patient on lifestyle changes and lifestyle goals, but you're also able to change the treatment at the same time. Point of care assay methods for HbA1c are not recommended for diagnosis. I think we must be also cognizant about the fact that there are factors that limit the use of HbA1c. And these factors are shown in the slide. They include erythropoiesis. Increased HbA1c values can be seen in iron deficiency states, vitamin B12 deficiency states, and states where there is a reduction in erythropoiesis. Conversely, you can see low HbA1c values in patients who are receiving erythropoietin therapy or iron and vitamin B12 therapy. You can also see reduced HbA1c values in reticulosis as well as chronic liver disease. HbA1c values can also be affected by halted hemoglobins. So HbA1c values can be increased or reduced where there is genetic or chemical alterations in hemoglobin, such as seen in hemoglobinopathies, HbF, and methemoglobin. HbA1c values can also be affected by the presence of glycation, and increased glycation products can be seen in alcoholism, chronic kidney disease, and intraerythrocyte pH changes. Reduced HbA1c values can be seen in patients who take aspirin even though they are in small doses. Reduced HbA1c can be seen in certain hemoglobinopathies, in patients who are consuming vitamin C and vitamin E. Erythrocyte destruction is yet another factor that limits the use of HbA1c because it can affect the HbA1c values that are reported. So any condition that increases the red cell lifespan can potentially increase HbA1c values. Conversely, any condition that shortens the red cell lifespan can reduce HbA1c values. And these include splenomegaly, certain hemoglobinopathies, rheumatoid arthritis, and drugs like antiretrovirals, ribavirin, and dapsone. There are also assay interferences. Increased HbA1c values can be obtained in patients who have high bilirubin levels, or in patients with renal failure where there is a high proportion of carbonated hemoglobin. Patients who are consuming large doses of aspirin may have large quantities of acetylated aspirin that affect HbA1c values. Patients who are in chronic alcoholism and chronic opioid use that can also cause increased HbA1c values. Decreased HbA1c values can be seen in hypertriglyceridemia, and variable HbA1c values can be seen in a variety of hemoglobinopathies. There are also age and racial disparities in the interpretation of HbA1c, and I think it is important to be cognizant of all these factors when you're interpreting HbA1c values. Now, one of the things I actually mentioned was hemoglobin variants. So far, there are over 1,500 hemoglobin variants. I think even as I speak, there are probably more and more being discovered every day. And the majority of these variants arise from point mutations in the alpha, beta, gamma, or delta hemoglobin chains. Now, the majority of these variants, actually the more common hemoglobin variants are HbS, HbE, HbC, and HbD. And these variant hemoglobins may increase HbA1c values, they may reduce HbA1c values, or in fact have actually no impact whatsoever on HbA1c values. Thus, the extent of interference depends on the method used, and laboratories therefore have to know the population they serve, the type of hemoglobinopathies that are present and prevalent in that population, so they can therefore choose the correct and appropriate method for their population. I think to help laboratories, the NGSP has produced a list, okay, and this list shows the different HbA1c methods, right, as well as the interferences caused by the presence of HbC, HbS, HbE, and HbD, as well as HbF and carbonylated hemoglobin. So if you are offering HbA1c and your population has a high prevalence of HbE, you may actually choose to select a method where the interference by HbE is as minimal as possible. And this list is constantly updated in the NGSP website. So I'm just going to move on to case studies. So I'm just going to move on to my first case study, and this is patient 1. Patient 1 is a 43-year-old female with coronary artery disease, and she had an oral glucose tolerance test to identify potential underlying risk factors, because 43 years old is fairly young for a patient with coronary artery disease. So she had a 2-point oral glucose tolerance test done. Her fasting glucose level was 6.2 millimoles per liter, and her glucose at 2 hours or 120 minutes was 7.2 millimoles per liter. Okay. She also had a lipid panel done, and essentially her cholesterol level was a little bit high, but her triglyceride level was acceptable. Our optimal values are less than 1.7 millimoles per liter. HDL was desirable, in fact optimal, and her LDL measured was actually 3.85, which was actually high. So just as a recap, these are the cutoff values for glucose levels during an oral glucose tolerance test. A patient is deemed to be non-diabetic if the fasting glucose level is less than or equal to 6.0 millimoles per liter, and that is actually equivalent to 108 milligrams per deciliter, for those of you who use SI units. A patient is deemed to be non-diabetic if his 2-hour plasma glucose level is less than or equal to 7.7 millimoles per liter, or 139 milligrams per deciliter. A patient is deemed to have impaired glucose tolerance, or IGT, if the fasting glucose level is less than or equal to 6.9 millimoles per liter or 125 milligrams per deciliter, and the 2-hour glucose level is between 7.8 to 11.0 millimoles per liter, which is equivalent to 140 to 199 milligrams per deciliter. Diabetes is diagnosed if a patient's fasting glucose level is greater or equivalent to 7 millimoles per liter or 126 milligrams per deciliter, and the 2-hour glucose level is greater or equal to 11.1 millimoles per liter or 200 milligrams per deciliter. So let's go back to patient 1. So this patient is 43 years old. She has a history of coronary artery disease. You already know that her LDL cholesterol levels are high and these need to be treated. And based on the cutoff limits for the oral glucose tolerance test, this patient is diagnosed to be non-diabetic. Let's move on to patient 2. Patient 2 is a 52-year-old male who presented with a groin abscess. This patient has a BMI or body mass index of 30.2 kilograms per meter square. And for patients who actually present with abscesses or infections, okay, we usually would proceed and order an oral glucose tolerance test to assess whether the patient has got underlying diabetes or not. For this particular patient, his fasting venous glucose level was 10.4 millimoles per liter, and do note that our reference ranges are actually 4 to 6 millimoles per liter, so this level is high. The patient's glucose at 2 hours was 20.6 millimoles per liter. So it's really quite evident that this 52-year-old patient has got diabetes. His fasting venous glucose level is greater than 7.0 millimoles per liter. It's actually 10.4, and his 2-hour glucose level at 20.6 is far in excess of the 2-hour cutoff for diabetes, which was 11.1 millimoles per liter. So this patient is a clear-cut diabetic patient, and this could account for him actually developing groin abscesses. Let's now move on to patient number 3. Patient number 3 is a 41-year-old female who presented with a urinary tract infection. She's got a BMI of 34.6 kilograms per meter square, and she also had an oral glucose tolerance test done. The fasting venous glucose level was 5.8. Okay, and the glucose level at 120 minutes or 2 hours was 8.4 millimoles per liter. So what does this patient have? Coming back to the table, this patient actually has impaired glucose tolerance. You can actually see that the fasting glucose level is less than 6.9 millimoles, which is actually the cutoff for IGT, but the 2-hour glucose level is well within the 7.8 to 11.0 millimole range, which is implicit for the diagnosis of IGT or impaired glucose tolerance. Let's move on to patient number 4. This is a 21-year-old male who has a history of fatty liver, and again, this patient actually had no previous medical history, and we also would usually do an OGTT to assess if these patients actually have underlying conditions that could predispose them to fatty liver. The patient's fasting venous glucose level was 5.8 millimoles per liter, and his 2-hour glucose level was 5.3 millimoles per liter. Okay, in addition to that, you can see that we did other tests, and his measured LDL cholesterol was significantly raised at 4.63 millimoles per liter. So, what is the diagnosis for this patient? Well, if we use this table, we would actually classify and diagnose this patient as being non-diabetic. But I think what is actually something to take note of here is that the 2-hour value is lower than the baseline value. So the 2-hour value is actually 5.3 millimoles per liter, whereas the baseline value is 5.8 millimoles per liter. So any thoughts on this? I'm sure some of you may have come across this kind of results before, and I certainly know that we've come across this in the lab. And one of the things that my laboratory staff will actually think about is, did we mislabel the samples at the point of collection? Okay, so maybe we should go back and look at the fundamentals of what needs to be done before and during an oral glucose tolerance test. The oral glucose tolerance test should not be done during an illness, as the results may not reflect the patient's glucose metabolism when healthy. So actually, this patient actually was not ill. He had actually recovered by the time we did the oral glucose tolerance test. The OGTT should preferably be done in the morning, and that's because glucose tolerance can exhibit a diurnal rhythm with a significant decrease in the afternoon. This OGTT was actually done in the morning. Medications such as large doses of salicylates, diuretics, and anticonvulsants and oral contraceptives can affect the OGTT. This patient was not on any of the medicines listed in this slide. What do patients need to do in preparation for the OGTT? Well, the patient should take adequate carbohydrate of at least 150 grams for 3 days before the day of the test. And this is usually not an issue in Asian countries because we take carbs as a staple. The patient should also fast for at least 8 to 12 hours before the test, although water is allowed. And I'm usually quite strict about instructions because I think people tend to forget that fluids are included in the ban list, and they have to be very mindful that they should not be actually taking even coffee or tea. The patient is then given a 75-gram glucose solution to drink, and this really should be drunk within a 5-minute time frame. And during the 2 hours, which is the time between the first blood sample and the second blood sample, the patient may read, may listen to music, talk, or do a quiet activity while waiting. He or she should not smoke, should not eat, or should not drink. And I think many of you are very familiar with these preparations that the patient should actually understand before the OGTT, as well as the requirements that should continue during the course of the oral glucose tolerance test itself. So what happened with this particular patient? So this particular patient actually had his blood taken at 0 hours, and he had his glucose drink and drank it within 5 minutes. And then he was told that the next blood sample would be taken in 2 hours' time. Most oral glucose tolerance tests are actually done in the outpatient setting. So he got a bit bored, decided he was going to walk home to collect something. So he walked 1 kilometer home and he walked 1 kilometer back. And by the time he came back, he was all ready to have his second sample done. And voila, glucose of 5.3 millimoles. When we found this out, we actually rendered this OGTT has been invalid and had to reschedule him for an OGTT on another day. And I think it's therefore important to make sure that your patients actually understand that they do need to not to move around during the course of the 2 hours, because it does change the validity of the test. Let's now move on to HbA1c. So HbA1c can be reported using NGSP-DCCT units, which is in percentages, or you can report HbA1c in IFCC units, which is millimole per mole. Patients are assessed to have good glycemic control if the HbA1c falls between 6.5 to 7%, and patients are deemed to have poor glycemic control if the HbA1c exceeds 8%. The methods for we actually measure HbA1c at point of care in the laboratory in my hospital, and fundamentally we never report any value greater than 14%. And this is where we actually have to explain, as we teach our patients, that it's not a 0 to 100 scale. The minute your HbA1c is 8%, it means that your glycemic control is really very poor and needs to be optimized. So let's move on to patient 5. So patient 5 is a 23-year-old male, BMI of 28.8 kilograms per meter square, and he is a known diabetic on oral medication. His random venous glucose is 10.1 millimoles per liter. His HbA1c is 8.3%, which means that his glycemic control is unacceptable. Patient number 6 is a 48-year-old female who presented with thirst and polyuria, and she has a BMI of 22.4 kilograms per meter. She was actually admitted to hospital on the 16th of July, 2020, and at the time of admission, her glucose level was 17.2 millimoles, and we also measured ketones beta hydroxybutyrate, and this was 0.06. She received insulin and sliding scale insulin, and on the 17th of July, you can actually see her glucose levels stabilizing with a lower level of 9.5, and she was discharged on the 17th of July. Okay, HbA1c level on 1st of September was 9.0, and this is actually 3 months after her admission. It's still unacceptable, but you can see that from September to October to December and eventually to April this year, HbA1cs are now moving from an unacceptable range to, in fact, an ideal range. And what has happened during the course of time is that she has moderated her diet, increased the exercise, and we've actually managed to switch her from insulin to oral medication because she has actually improved her lifestyle measure so much that she no longer requires insulin to maintain her diabetes. Okay. Patient 7 is a 35-year-old male who presented to A&E with weight loss and sudden onset of thirst and polyuria, BMI of 22.7, and this 35-year-old male was admitted on the 3rd of July. On the 3rd of July, HbA1c was 14.1%, and a corresponding random venous glucose was 23.6. This patient had multiple glucose levels taken through the course of the day. These levels range from 22.1, 17.5 to 12.5, and eventually to 10. And plasma beta hydroxybutyrate levels were raised at 3.55. So what did this patient have? This patient actually presented in DKA, or diabetic ketoacidosis. This patient was discharged in late July and returned to clinic 1 month later. Note that HbA1c at his first clinic appointment is now 7.4%. And over the next few months, you can actually see he was readmitted on the 13th of September. And by the time he came back in on the 6th of October, HbA1c is now, in fact, ideal, even better than optimal. And this is again achieved by a combination of adjustment of insulin, oral medications, as well as lifestyle measures. So this patient presented with DKA. His initial picture was that of DKA with a raised plasma ketone value. And over time, HbA1c values have fallen because of adjustments of medication and improvement in lifestyle measures. And hence, 3 to 4 months, 5 months after his original admission, he has managed to keep his diabetes under control and now has a HbA1c of 5.9%. I think we are recognizing that blood glucose monitoring, or BGM, is an essential part of diabetes management, and all diabetic patients are advised to do BGM. Glucose meters have also become smaller, more accurate, more widely available, require less blood, and provide readings rapidly. And we tend to advise our patients to do both pre-meal and post-meal BGM checks, and we call this BGM couplets. Pre-meal readings, as I mentioned in one of my earlier slides, should ideally be between 4 to 7 millimoles, and 2-hour post-meal glucose readings should ideally be between 7 to 10 millimoles. And again, if a patient can achieve these targets, most of the time they can be assured that by the time they are reviewed by their doctor, the HbA1c levels should usually be between 6.5 and 7 millimoles, which is the optimal range. Patients who consistently obtain pre-meal and post-meal levels above 7 or even 10 can be assured also that by the time they actually see the doctor, the HbA1c levels will be either suboptimal, unacceptable, or unacceptable. So BGM actually gives a patient the opportunity to manage their lifestyle, as well as the doctor's opportunity to adjust medicines, so that by the time the patient is reviewed, all the necessary steps have been taken to optimize glycemic control. So this is patient 8. Patient 8 is a 59-year-old female who's had diabetes for 6 years and has got hypertension and hyperlipidemia. Patient 8 was treated with oral hypoglycemic agents, insulin ACE inhibitors, and statins, but despite medication adjustments, the HbA1c remained raised at 9.2%, and the patient kept insisting that she was actually taking her medications regularly, and her BGM readings were actually satisfactory for both pre and post-meal. These are her laboratory investigations. HbA1c was 9.8%, and you can see her fasting glucose is 6.6 millimoles. We did a full blood count. Hemoglobin was 11.8. But what is of notable is that her MCV was low at 70, and her MCH was 22, which is below the reference range of 26 to 32. This is her chromatogram. And if you compare it with that of a diabetic patient, you'll notice that she actually has an additional peak. So what is triggering here is, does this patient have a hemoglobin variant? So how do hemoglobin variants actually affect HbA1c? So these are sample chromatographs. So let's start off with box A. So box A shows the chromatogram of a patient who actually has no hemoglobin variant. So you have HbA and you have a small HbA1c portion. In box B, this patient has hemoglobin variant HbX as well as a corresponding glycated portion, which is known as HbX1c. However, HbA is clearly separated from HbX during elution, and HbA1c is separated from HbX1c, and therefore HbA1c levels are not affected by the presence of the variant. In box C, HbX actually elutes with HbA1c, and this leads to gross overestimation of HbA1c. In box D, HbA1c elutes with HbA1c, while HbA is separated from HbX, and this leads to, again, an overestimation of HbA1c. In box E, HbX1c is separated from HbA1c. However, HbX co-elutes with HbA, and this leads to an underestimation of HbA1c. This patient had hemoglobin E trait. HbE is commonly encountered in regions of Southeast Asia, and this beta hemoglobin variant comprises one normal adult beta gene and one variant HbE beta gene, and presents with a very mild form phenotypically of beta thalassemia. HbE1c frequently elutes, has a shoulder to HbA1c in most HbA1c, HbLc, or cation exchange chromatographic methods, and may be spuriously increased or decreased. However, immunoassay methods and boronate affinity methods are not affected. And consequently, this patient actually had a peripheral blood film done, and which showed normal red cell morphology. The HbA1c by immunoassay was 7.1%, which actually correlated with her BGM readings. Patient 9 is a 51-year-old man who was diagnosed with diabetes in 2006 and has concomitant hypercholesterolemia and hypertension. In 2006, was started on oral hypoglycemic agents, statin, ACE, and aspirin. In 2011 was started on insulin because the glycemic control remained high. Despite insulin, the glycemic control continued to remain suboptimal. His HbA1c was 9.1 to 9.8%, although the patient's BGM results were satisfactory for both pre and post-meal readings. Patient's 9 laboratory investigations are shown here. HbA1c is 11% and the fasting glucose was 8.2 millimoles per liter. And like the previous patient, we also did a full blood count, which was unremarkable. MCV, MCH, hemoglobin were all normal. We sent off the specimen for an alternative method, and the result was similar. We also ordered a thalassemia and hemoglobinopathy screen, and it was actually negative. So what was actually happening in this patient? So we also recognize that BGM only captures snapshots, okay, of a patient's lifestyle. And about 10 years ago, for these patients, we advised them to go on CGMS, on continuous glucose monitoring systems, where they wear a sensor, and the sensor actually measures their glucose levels over either 48 hours or, for that matter, a week. And what this patient was, and what was happening to this patient was, when he did his BGM, he actually was doing BGM during the weekdays. And this, you can see from the CGMS, that all his readings, both pre and post meal readings during the weekdays, are really very good. But on the weekends, all the readings were actually sky high. Okay, and I called this the weekend effect. And he actually told me that in work, he actually followed a very strict dietary regime, but over the weekend, he was attending wedding dinners and all sorts of meals, and that's where the HbA1c readings were reflective of this. What we did for this patient was we adjusted his medications and gave him more during the weekends, but we also told him that he had to actually moderate his meals over the weekends. Let's move now to patient 10. So patient 10 is a 44-year-old male, was diagnosed with type 1 diabetes in 2005 and was started on metformin in 2005 and insulin in 2006. This patient is hyperlipidemia. His BMI is 23.8 kilograms per meter square, so he's not obese. And his HbA1c is consistently above 8%, and like the previous patient, BGM readings were satisfactory. So this is actually patient 10. You can see that from the period of 11th December 2018 for the following year, his readings for his HbA1c values were consistently over 8% and remained over 8% despite increases in insulin over the period. So what was actually happening to this patient? Again, this is a reflection that intermittent BGM readings are not necessarily representative of a patient's lifestyle. And for this particular patient, he decided to go on the Libre system. So the Libre sensor is a sensor that uses subcutaneous wired enzyme glucose sensing technology to detect glucose levels in interstitial fluid, and glucose is measured every minute. You can either buy a reader or use your handphone, and the minute you put it near the sensor, you actually get the glucose reading at that point in time. In addition, the sensor also displays the past 8 hours of glucose information, including the current glucose, a trend graph, as well as a trend arrow. So this is a snapshot of the Libre view, and what appears at the top is the estimated A1C value. And for this particular patient, the estimated A1C value was 7.2%. And this graph illustrates the glucose levels over the course of a 24-hour day. The Libre is worn for 2 weeks. And usually in the first week, readings are considerably worse than the second week, because by the time they get to the second week, you would have expected the patient to actually adjust their lifestyles to try and ensure that glucose levels are well within the pre and post meal targets. So for this particular patient, you can see that for both weeks, there are very, very high glucose levels, and these glucose levels are all above the shaded lines. You can also see days where the glucose levels are below the shaded line. So this patient was actually having hyperglycemic episodes as well as hypoglycemic episodes. And this was again reflected in the HbA1c. So what we did for this patient is that we reduced his night insulin and increased his morning insulin and told him to moderate his meals, particularly his lunch meals, which were way over the targets. So in conclusion, diabetes mellitus refers to a group of metabolic diseases characterized by hyperglycemia resulting from defects in insulin secretion, action, or both. And laboratory tests such as glucose and HbA1c, are essential in diagnosing and monitoring diabetes mellitus. I think interpretive comments are very useful adjuncts in assisting clinicians in their management of diabetic patients, but it's not, I think for diabetic patients, it's not just laboratory tests that actually give the clinicians a sensing of how their patient's glycemic control is, but these laboratory tests are also increasingly being complemented by point of care tests such as blood glucose monitoring, and together they provide a much more comprehensive picture of the patient's overall clinical condition. This actually helps both clinicians as well as laboratorians play a much more united role in patient care and patient management. So I've come to the end of my talk, and I'm actually very happy to take any questions.
Oh, thank you so much, Dr. Wong, for this great talk and all the information that you've shared. So I'm monitoring the chat room for questions. We don't have any at the moment, but please feel free to type in your questions in the chat room. So I see there's one comment now. Thank you for the great talk. I noticed you didn't cover type 1 diabetes as much as type 2 diabetes mellitus. I was wondering what your local policy is for diagnosis or prediction of T1DM.
Okay, so for actually T1, if we suspect, well, firstly, I think that type 1 diabetes is actually not as common as type 2 diabetes. And also for type 1 diabetes, the patients tend to present with very clear features suggesting they're actually type 1. For type 1 diabetes, we do measure antibodies. Okay, this is fairly customary. And we measure GAD antibodies, insulin antibodies, but the treatment still remains the same. We still have to give them insulin, and we still need to bring their sugar levels down accordingly. So yes, we do measure antibodies, but we don't see as many type 1 and patients as much as we see type 2.
Thank you, Dr. Wong. So are antibodies part of the diagnostic criteria for type 1 then?
We do. Yes, we actually do it, although some are very clearly type 1 that we don't even proceed to do antibodies. It's for the patients where we're not quite clear whether they are type 1 or possibly even a type 2 that we proceed to do antibodies. And if they are actually antibody positive, that more or less reinforces our conviction and our diagnosis that they are truly insulin deficient.
I see, thank you. How about the measuring of insulin or C-peptide?
Oh, we don't measure insulin and we don't measure C-peptide in patients with diabetes. I think there's only been very few instances where we've actually measured, no, actually come to think we don't actually measure insulin at all. There have been occasions, but like I said, very few cases where it's a stimulation test, and what we're trying to see is whether a patient can actually produce insulin, but again, not very frequent.
Okay, thank you. While we're waiting for more questions, I had one about HbA1c variants, and thank you for sharing that case. So I'm wondering how would you manage a patient who is a known HbA1c variant like you shared? Would you switch to a different HbA1c assay? If that's not available, how do you, what's the next step?
So I think the first thing is actually establishing that the patient actually has a HbA1c variant, HB variant. So once you've established that this patient has a HB variant, you would continue to monitor that patient on a method which has no or minimal interference by that variant. So HBE is fairly common in Singapore. We recognize about 3% of the Singapore population has HBE. Okay, so we do use HbA1c for HbA1c measurements, but for these particular patients, once we've actually identified, like that particular patient I shared, we would never measure this patient's HbA1c on HbA1c. It would always be on immunoassay. And what you can do is that these patients tend to be followed up by the same clinicians in the same hospital, and you can actually tag it in your laboratory information system that when this patient sample is received, do not measure using HbA1c HbA1c, you can tag it to say measure by immunoassay. So that's how we normally manage our patients with HB variants.
I see. Thank you very much. And we have a follow-on question from Dr. Shrafan. Do you suggest fructosamine testing as an alternative in these variant patients?
Okay, this has actually been long debated by many of us here. Fructosamine was popular at one time, and it was really only used in the pregnant women population. Okay, and that's because it is actually a much shorter marker than HbA1c. It has, in Singapore, I don't know many doctors who are actually ordering it, and I think part of the reason is because when we manage, I have some pregnant patients that actually I have to take care of them. We have very, very clear targets for blood glucose monitoring. Okay, and these targets are extremely tight. So that the BGM frequency of monitoring as well, the target seems to have superseded fructosamine. So I don't think I've actually received any requests for fructosamine for many, many years. And certainly I don't actually see it superseding or replacing fructosamine, HbA1c at all.
I see. Thank you for sharing. I have one question here. I'm not completely sure I understand it. It says, why in iron deficiency HbA1c? Any mechanism behind that?
So in iron deficiency, HbA1c can go up, and that is again, I believe, to some extent related to the lifespan of the red blood cell. So I believe that is one of the reasons why. I think it's not just iron deficiency, but also B12 deficiency. So it does seem to be correlated to the red cell itself and the nature of the red cell itself. But I have to admit, I'm not quite sure of the underlying pathology or pathophysiology for this. I think it's just important to be aware that patients with B12 and iron replacements and deficiencies can potentially have HbA1cs that are not necessarily accurate.
Yes, thank you for reminding us of that. We have a question about HbA1c immunoassays. Does it mean this is a total glycated hemoglobin, biboronate affinity, or specific HbA1c?
So the different immunoassays actually have different antibodies targeting different regions. I think first is you really need to be cognizant of what your assay is measuring. While HbA1c methods do have interferences by hemoglobin variants, we also know of immunoassay methods that also have interferences by hemoglobin variants as well. So I don't think there's actually one perfect method, but rather you need to be aware of the limitations of the method that you are offering to your patients. And if the HbA1c doesn't correlate with the BGM results, then there's obviously something going on that needs to be further investigated. I think in the past, before blood glucose monitoring was prevalent, it would have been difficult for us to actually spot, possible variants. But when you do advise patients to monitor and those results are so totally different and discordant with the HbA1c, obviously there is something that merits investigation, and it could be a true HB variant, it could be another interference, or for that matter, it could be an assay issue. So it really is just a trigger. Is there something going on, and where do I go from there?
Yeah,
so I don't think every immunoassay is perfect, and I don't think immunoassays are superior to HPLC.
Yeah, and definitely there are a few different technologies for measuring HbA1c, right? As you mentioned,
Yes.
chromatograph, HPLC,
Yes.
immunoassay. There's even enzymatic methods.
Yes, that's right. So I find that, the NGSP, they've actually published this list of the different HbA1c methods available and the interferences by the common hemoglobin variants. And that's a very useful list to go through, because if you're not sure that the method you're using has interferences, that list actually provides very good guiding principles. It also does help laboratories select the right method for that particular population.
Uh, so we have a question: which is the best method to measure HbA1c?
As I said, there isn't really any best method. I actually use immunoassays in my laboratory. We use it on the mainframe. I also have point of care HbA1c, which also uses immunoassays. So it's it's actually very gratifying to know that my HbA1c result on my immunoassay analyzer will correlate with my HbA1c result on the mainframe that uses immunoassay. But we also, and I think where the HbA1c result on the immunoassay does not correlate with with the BGM, that's when I start looking at other things. Why I use immunoassays, I think firstly, shorter turnaround time, and it's also on the mainframe. Many immunoassays are actually part of mainframe automation analyzers, so it saves me from having to have a separate workflow. And I think when we're looking at turnaround times, because one of the things I mentioned earlier on was that HbA1cs should really be done at the point of consult, is that you do need to make sure that result is available for the patient during that time of clinical consult. So I use immunoassays, but I also actually have a standby HPLC, and therefore discordant results or suspicious results on immunoassays, those specimens are actually sent to HPLC for confirmation.
Let's see. And while we're on the topic of immediate results, we have questions on point of care HbA1c instruments. There was a comment by Dr. Schaffen that in Australia, point of care for HbA1c for diagnosis of diabetes is approved for indigenous Aboriginals, provided the lab is enrolled in the RCPA QAP program. But we have a question like, since you said it's not recommended for diagnosis, is it then still recommended for monitoring?
Okay, so I will take the question in a few parts. So HbA1c in Singapore has only just recently been approved by our ministry to be used as a potential diagnostic marker, meaning that there's a range, and if the patient actually has a HbA1c within this range, then this patient should proceed for confirmatory testing. And how that has come about is because we have a national program for HbA1c, and all laboratories who wish to use HbA1c for diagnostic purposes must subscribe to this proficiency program, which is actually based on accuracy methods. Okay, so it's not based on consensus. So we actually have a national proficiency testing scheme. And if you want to offer HbA1c for diagnostic purposes, you need to subscribe to it. At the moment, the scheme is just limited to mainframe analyzers. Okay, and that's because we are much more familiar with how HbA1c performs on mainframe analyzers. That is not to say that in a few years' time, when we have a better understanding of the performance of HbA1c on point of care analyzers, that it cannot be used as a diagnostic marker. The other dilemma we actually had was what's a point of care and what's a mainframe. So for us, a mainframe is anything in the laboratory, but we also recognize that we actually have all these little point of care analyzers in the laboratory as well. So it wasn't so much about point of care versus mainframe. It really was about the competency of the staff handling these instruments and whether they knew what to do with the results. So I think the definition of point of care became a little vague because we suddenly realized that in our own labs, in addition to mainframe analyzers offering immunoassays as well as HPLC, we also had DCA 2000s, and we also had the Roche B101s all inside our labs. So we've decided for now we would just use HbA1c results on mainframes first. We haven't actually gone into point of care instruments just yet. So I think Australia is probably way ahead of us in advocating HbA1c as a diagnostic marker for Indigenous populations. We're not there yet.
I see. But for monitoring point of care,
monitoring, not an issue. Monitoring is very clearly indicated. We're finding that diagnosis is a challenge. So I think the HbA1c standardization program has done a lot in ensuring that HbA1c is a robust marker, whether it's done on mainframe analyzers or point of care. Monitoring is not an issue.
I see. Okay, I know we're a little bit running out of time now, but we have one last question. For again about the variant hemoglobins. In this case, would using glycated albumin be beneficial?
I personally don't have much experience with glycated albumin. I vaguely remember that this was also discussed in the same forum as fructosamine. Glycated albumin, fructosamine, and it really has not taken off in the Singapore context. So we don't use it at all here. I don't think I know of any laboratories in Singapore that offer glycated albumin.
Okay. Yeah, thank you for sharing. And there was a comment that the glycated albumin is popular in Taiwan. So maybe we can have someone from Taiwan comment on this at a future point. Okay. I just came in one last question, so we'll stop this question at this Q&A at this last question, so that we don't keep Dr. Wong forever. Okay. But this question is in ion exchange HPLC. If we detect variants in chromatogram, is it necessary to proceed with hemoglobin analysis to identify the variant?
So this very much depends on the policy and the practice of that particular area. I think if you are actually monitoring the patient for HbA1c for diabetes, and you know that a variant is present, you can do one of two things. You can identify the variant, and because you know it is actually interfering in HPLC, you would do it on immunoassay method. I think the second alternative method. So I think the fact is that if you're looking after a patient and you're actually using HbA1c for your patient's management and you know it interferes, then you have to actually find an alternative method. Okay, do you need to proceed to identify the variant? I know of clinicians that actually just proceed and use an alternative method, but they don't necessarily identify the variant. But I also know of clinicians who actually proceed to measure HbA1c by an alternative method and at the same time order a test to identify the variant. But I think most important of all is to actually recognize that there is an interference and find an alternative method that has very little interference with that variant. But whether you want to identify or not is very much an individual practice, I think.
Okay, thank you for sharing. Okay, great. So thank you. We've come to the end of the Q&A. Thank you very much, Dr. Wong, for sharing with us today. And thank you to everyone for your participation. I'll let Dr. Elena just close the session and say a few words.
Thank you so much, Dr. Wong, for that very informative lecture. I'm sure participants have found it very useful. I think if you allow, there are still more questions coming in. I see a lot of interest in this topic. Thank you so much also for taking all the questions. And we hope that you will come back again and in the near future to share with us a lot more of your experience. So on behalf of APFCB, thank you so much.
Thank you very much, Dr. Lena. Thank you.
So to all participants, thank you also for joining us in the APFCB Masterclass. So we hope that you will join us in the coming the next program. So look out for the announcement. We'll be sending it out soon. And you can visit the APFCB website for more information. So thank you very much.